Hey everyone, we're back with another video for our postoperative complication series, and today we're going to talk about decreased urine output. And why do we care? So decreased urine output is a marker of kidney function as well as total body volume status. And volume status is actually something that's really difficult to keep at the appropriate level post-op because there's a lot of fluid shifts. Patients can't maybe eat or drink the way they normally would, and it's really easy for the system to get out of whack. So we are really careful about monitoring the urine output to keep us on the right course there. And then, secondly, urine output is often the first sign, kind of the canary in the coal mine for a lot of other underlying badness or postoperative complications such as sepsis, bleeding, uh, etc. So, both in terms of usually a little bit of decreased urine output is fine. It just means a few little tweaks in our postoperative fluid management. It can also be an important early warning sign of a postoperative complication that we want to get on top of and manage right away. So we pay a lot of attention to this. And to pay attention to your urine output, first you need to know what a normal urine output is. And so the easiest way I found to think about this is just this 0.5 cc's or milliliters per kilogram per hour rule. And so for your average 70 kilogram person, that's around 35 cc's per hour. So you can look in the EMR, and if you can get an easy per hour calculation, that's one quick way to look at it. The other way that it's typically reported in the EMR is your urine output per an 8-hour shift. So if you take your average person and your average, so 70 kilograms, 35 cc's per hour, and then multiply that times an 8-hour shift, that's around 250 cc's per shift. So when you're quick reviewing your EMR in the morning, going through your patient list, a lot of times I look at the last shift, the overnight shifts, urine output. If that's around 250, I'm usually pretty happy with that. But if it's not, now we have to start thinking about, okay, what do we do? What are the first steps? And so step one, especially in the post-op patient, is almost always just give a fluid bolus. Like, don't even think too much about it. Just give a liter or maybe 500 cc's of an isotonic fluid. I believe we talked about this before, but anytime you're resuscitating a patient because you think they don't have enough fluid, you want to be giving an isotonic fluid. That's typically something like lactated ringers or normal saline. We definitely do not want to be giving a hypotonic fluid like D5 half normal saline, and then we almost never use things like hypertonic fluids like 3%, things like that. Like, that's for very specific neurologic situations. Your half normal saline, your hypotonic fluid is going to give you too much water that's going to go into your third space. And so when we're resuscitating, always think isotonic, always think LR or NS. And the reason I say that this is step one is we're almost always dealing with hypovolemia when we're thinking about decreased urine output in the postoperative period. And there's just tons of reasons for patients to be low on fluids in the postoperative setting. First, you got to think about what's been going on around their surgery, right? Usually they've been NPO, nothing to eat or drink, since about midnight the night before. Obviously, they weren't eating and drinking during their surgery. And then frequently post-op, they're nauseous, they don't feel like eating and drinking, or we're not letting them because we're worried about an ileus. Of course, there's fluid losses in the OR. EBL, or estimated blood loss, is probably the most obvious one, but you can lose a lot of other fluids besides blood. Frequently, there will be an NG or an OG tube in, so you'll lose those. Of course, patients are still making urine during the case. You've got to take into account urine output. Additionally, there's just insensible losses in the OR. This is really an issue in open surgery, even much more so than laparoscopic. Obviously, your organs are used to this nice, friendly intra-abdominal environment where there's lots of fluid, there's no air, there's no evaporation. When you have your abdomen open to the air, you can get insensible losses of about 1 liter, like a complete liter every hour, that needs to be repleted, in addition to any other sorts of fluid losses that were happening during the case. And frequently, if you calculate post-op, they have not met this sort of rule of thumb requirement. And then anytime you're having surgery, right, you're being cut open, your organs are being manipulated. So that's a pro-inflammatory state. So just like, I think of it kind of like a mini sepsis, right? So your blood vessels get a little bit leaky, you lose some fluid out into the third space that we need to replete until your vessels become not so leaky anymore a couple days post-op. And then, of course, just like their NPO pre-op, we said they're often NPO post-op. Oftentimes they have an NG tube in post-op that they're losing fluids. Sometimes people start them on a really low resuscitated fluid rate or maintenance fluid rate. So all these things can lead to your patient being volume down, and usually a fluid bolus will pick their urine output right back up. And so because this is so related, right, you want to be thinking, okay, maybe my patient didn't get enough fluids. I give them a bolus, they got better. I want to make sure that I'm really giving them the right amount of maintenance fluids so they have enough volume going in, and we don't have to keep having their urine output drop and bolus them, etc. So the most common way we think about calculating maintenance fluids, or just fluids that you have running in consistently through an IV the whole time while you're NPO, is this 4-2-1 rule. And this is just based on the patient's body weight in kilograms. It's a calculation. And so the way this works is that the first 10 kilograms you multiply by 4 cc's per kg, the second time 10 by 2 cc's, and then the remaining kilograms that you haven't taken account of here, you multiply by 1 cc per kg. And this whole calculation is really important for like pediatrics, for example, but in adults, if you think about it and simplify it, this whole formula ends up being equal to adding 40 cc's an hour to the patient's body weight in kilograms. So just to give an example, let's say we have your average person, 70 kilograms. We take those first 10 kilograms, we multiply it by 4, and so that's 40 cc's an hour. We take the second 10 kilograms and multiply that by 2. That's 20 cc's an hour. And then we take the rest, so 10 plus 10 is 20. We subtract that from 70, so we have 50 additional kilograms. Multiply that by 1, that equals 50. We add all these up. Be careful not to mess up my math here. That's 110 cc's per hour of maintenance fluids that we would want running. And so if we go back to the simplified formula, if we knew they were 70 kilograms, we just add 40. You can see that we would get that same 110 cc number. And of course, if you have to, for example, give somebody a bolus, or you think they're showing signs of under-resuscitation, you can titrate this up or down. This is just a general starting point that we like to think about. And so what are some other signs that your patient might be hypovolemic as a cause of their low urine output post-op? And so H&P is easy to forget, but really simple. Often if you just ask the patient, hey, are you thirsty? They'll tell you. They'll say they have things like a dry mouth. On the opposite end, if they tell you they're really puffy, or they feel like their hands are all swollen, that might be a sign of actually being volume overloaded. So we want to talk to the patient, as always. Vital signs: if a patient's under resuscitated or hypovolemic, their heart rate will usually be slowly uptrending. You can look at a ton of different labs to tell you a little bit about the volume status. Creatinine is a common one we're looking at every day. That will usually trend upwards with time if they're having a bit of an acute kidney injury, because an elevated creatinine is, of course, usually a sign that the kidney is not functioning as well. You can also look for the classic contraction alkalosis, which is hypokalemic, so low potassium, hypochloremic, low chloride, and then metabolic alkalosis, which is an increase bicarbonate. That is especially common when we have high acid losses, for example, in NG tube output from the stomach. And then another one is just hemoconcentration. So let's say one day your patient's hemoglobin was 10, and the next day it's 15. That's pretty strange. Your body's not going to make a ton of more red blood cells. So usually that means that you've lost some fluid or essentially like water in your bloodstream that was diluting this initial hemoglobin count down. And then finally, you've got to think about the clinical trend. So like I said before, let's say we have a graph of time, and maybe this is the day of the OR, right? And if we're talking about inflammation, your body's living its everyday life, boom, goes to the OR, reasonable post-operative and really intraoperative inflammatory stimulus, right? So inflammation is high, our capillaries are leaky, we're dilated, we're leaking some fluid into the third space, and this takes some time to go down. And usually it starts to really go down maybe post-op day 1 or post-op day 2. And so if your patient's in this early post-op day 1-2 period, I've got to be really suspicious that we're not giving them enough fluid, and that's the reason for them having low urine output. Whereas once we get beyond this time point, I'm a little bit more suspicious of other things because I don't think they should be losing fluid from just that normal kind of perioperative inflammatory state. In fact, what usually happens is we get to around post-op day 2, post-op day 3, the capillaries become less leaky and all the fluid comes out of your third space and they have a big increase in their urine output around that time. And that's usually a good sign, usually means patients are healing well. All right, so we had our hypothetical patient, their urine output was low. Remember, that's around less than around 250 cc's per 8-hour shift, typically, and fluid didn't work. So what do? And once again, since this is surgery and this is the post-op period, usually it's still hypovolemia. So oftentimes we'll try some more fluid, but of course there's a point where we want to start digging deeper and figuring out if there's something maybe beyond hypovolemia that's contributing to this problem. And so this is where we really start talking about the 3 types of acute kidney injury, or AKI. And so there's prerenal, intrarenal, and postrenal. So on this handy diagram of the kidney and the bladders, we'll just talk about these 3 causes mechanically. So prerenal, I'm just going to draw in here, right? So these kidneys obviously have to have a blood supply coming towards them. And so if there's an issue with the amount of blood or the ability of blood to make it to the kidneys, that can cause a prerenal acute kidney injury. So you can think about if we have this hypovolemia that we've been talking about, or bleeding, just something that's leading to there's not enough volume coming to the kidneys, that can cause a prerenal AKI. Although there can be other things, for example, heart failure, hepatorenal, even some really rare things that you wouldn't see in the post-op period, like renal artery stenosis, right, where there's an actual blockage here and the blood's not getting through. An intrarenal is a problem with the kidney itself. Something about the kidney and its glomeruli just aren't working the way they're supposed to, and that's causing a decreased urine output. These are usually things like ATN or AIN, can be hypovolemia, can be, I should say, an end-stage result of hypovolemia. So AKI can progress to ATN, it can be caused by toxins, etc. That usually is a waiting game where we're letting the kidney heal itself. And then finally, there's post-renal. And so that's something happening after the kidney where there's an obstruction to the urine being able to make its way all the way out of the body. So probably the most common in your post-op patients would be your old men getting surgery with their BPH, their enlarged prostates here at the bladder neck. You get a bunch of that extra fluid and edema from that surgery in that perioperative inflammatory state. You get a little bit more swelling in the prostate, and all of a sudden they can't get their urine out of their bladder. More rare causes would be things like a stone blocking the bladder, or extremely rarely, you'd have to block both ureters with stones. Sometimes people have intraoperative injuries to the ureters, but once again, that would have to happen on both sides. Those are usually quite rare, and really it's typically a bladder problem when we're talking about the post-renal obstruction. And so once we have that framework in mind that all of our kidney injuries have to be either pre, intra, or post-renal, we can start thinking about our systematic workup. And the first thing I like to do after my fluid boluses, when I'm really starting to work this up seriously, is just get a quick bladder ultrasound. This is not like a formal ultrasound. Most nursing floors will have things, they call it a bladder scan, to just quick scan the bladder, see if there's a ton of fluid in there, or just any normal ultrasound, just like a fast exam in trauma. You can look at the bladder and get a sense of if it's very full and distended or not. And that will usually give us a good sense of if there's a post-renal issue going on. And if that's not the case, now we're thinking, okay, is this pre or intrarenal? And some labs that can help us figure that out are or I should say calculations based on some labs, are the FeNA, or fractional excretion of sodium, or the FE-urea, fractional excretion of urea. And so to talk about that quick, these labs are used for the same, or these calculations are used for essentially the same clinical scenario. The key issue here is usually we're thinking about diuretics. If somebody's using diuretics, remember that those frequently affect sodium absorption and release in the kidneys. So if somebody's been on a diuretic recently, you're going to have to use an urea as opposed to a FeNA. But just to get a little bit of a sense of how FeNA works, so fractional excretion of sodium, remember that sodium is really what your body uses to maintain its volume state. It's not fluid per se, but the fluid has to have sodium with it. Otherwise, it just more or less dissipates into the third space, like if you were to give somebody D5W. And so when your body has a low volume status, your body wants to save sodium to help increase that volume status. And so what it will do is prevent the sodium from being excreted in the urine and reabsorb it. So the equation for FeNA, I would not recommend memorizing this. That's what we have things like empty calc for nowadays, but it's your urine sodium times your plasma creatinine over just the opposite, your plasma sodium times your urine creatinine. Like I said, don't memorize that formula. That's just to give you a little bit of intuition about the issue. If your urine sodium is really low, that means your body is trying to keep its volume status up. And so that's usually a sign of hypovolemia, which is of course a prerenal AKI. And so just to look at these numbers quick, if you calculate your FeNA and it's less than 1%, remember that's a very low amount of sodium being released in the urine. That's usually a sign of a prerenal AKI. If it's greater than 4%, that's usually post-renal. And if it's somewhere in between 1 to 4, that's frequently intrinsic renal disease. And then for an urea, it's a little bit less precise. Something around less than 20% is usually prerenal, and greater than 40% is something else, post-renal or intrinsic. And so now that we've done a little bit more digging into our causes of our acute kidney injury, we can think about treatments. So post-renal, this is usually one of the easiest things to think about and treat. You looked at the bladder, you saw it was dilated. Sometimes that bladder just gets too dilated where the muscles are unable to effectively squeeze and push urine out anymore, and you just need to do a single straight cath, get the urine released once, get the bladder back to a more normal size, and it's able to function normally. Of course, if you have a few straight caths and the bladder's still not making normal urine, still retaining, you might have to place a Foley, long-term Foley. And then if it's a higher problem, right, so a Foley or a straight cath won't prevent an issue with the ureter, that's a case where you might need something like a nephrostomy tube. And then finally, during all this, especially if you're talking about some BPH exacerbations or edema that you think is related to the bladder neck, some people will try alpha blockers like tamsulosin to help release that urine. But really, the thing to remember here, post-renal, this is usually some sort of mechanical obstruction, and you can deal with it usually by just dealing with that mechanical obstruction. And then next stop on our treatment list is intrinsic, and this is when there's an issue to the kidney itself, and really all you can do there is just wait for the kidney to heal. The kidney will almost always bounce back and start making normal urine again. But if it's intrinsic, you should probably stop throwing so much fluid at the problem and just let it resolve on its own. Of course, if this doesn't resolve, then that's a time to call renal and start getting their recommendations for how to deal with this problem, with, of course, the end stage, if your kidneys just stop working completely, being something like dialysis. And then finally, saved this last one, prerenal, for last, because it's usually the most complicated because there's so many potential causes. Like we talked about, post-renal is an obstruction. You just fix the obstruction. Intrarenal is just a problem with the kidneys. You just wait for the kidneys to heal. But prerenal, now you got to figure out, okay, so why is blood unable to get to the kidneys adequately? Usually that's hypovolemia. Usually it just means give more fluids, but it can be anything else that decreases your renal perfusion too. So you've got to really look at the whole clinical scenario, decide what's going on with your patient, and then treat appropriately. For example, something like CHF could also cause this. And of course, in that case, the heart's unable to pump blood forward, and usually too much fluid exacerbates that problem. So it's important to start thinking a little bit deeper if your initial treatments with fluids are not giving you the result you'd expect. And so that's it. Just to briefly review, we have our patient with low urine output. What do? Step one, give fluids. If the urine output picks up, they do fine. Great. If not, now we need to start thinking about our 3 buckets of AKI: prerenal, intrarenal, and post-renal. Usually one of the first steps, we get a quick scan of the bladder, rule out post-renal. Of course, if that is an issue, we treat our obstruction usually with a straight cath or a Foley. And then if that's not the case, now we're looking between pre and intrarenal, our FENA, or if the patient's been on diuretics, our FE-urea is usually a good clue here. If it points us towards intrarenal, we're usually just playing the waiting game. And then finally, if that's not the case and it's looking like a prerenal cause, we're going to once again make sure we've given enough fluid and then start to think a little bit more deeply about some potential other causes of prerenal AKI, things like heart failure, things like sepsis, etc. And so that's it. Hopefully you have a good sense of how to approach decreased urine output in the postoperative postoperative scenario. Remember, think about it systematically. It's usually hypovolemia. You usually just give fluids, but if you're struggling, break it down: prerenal, intrarenal, postrenal. Systematically figure out which one it is, and then you can think about treating it appropriately. These videos are for educational purposes only. Do not use them to diagnose or treat any diseases, and we will see you next time.